Welcome to Canadian Patient Safety Week and today's webinar, Expanding Perspectives, Understanding and Reducing Healthcare Harm. Bienvenue au webinaire Élargir ses perspectives, comprendre et réduire les préjudices liés aux services de santé. Si vous voulez participer en français aujourd'hui, sélectionnez French du menu d'interprétation au bas de l'écran. Si vous ne pouvez pas voir le menu d'interprétation, sélectionnez l'icône avec 3 points à l'intérieur d'un cercle, puis sélectionnez Interprétation. My name is Jennifer Zelmer, and I'm the CEO of Healthcare Excellence Canada. I'd like to welcome you to today's webinar. As you join today's webinar, we invite you to access the View Options menu at the top of the slides to select in which language you wish to see the slides today. If you're using a newer version of Zoom, you'll need to slide your, whatever those things are called, slide your mouse up to the top of the screen so that the menu comes up, and then you'll be able to choose the appropriate tab from the top of your Zoom screen. As we begin today's webinar, I'd like to acknowledge that we are joining today from lands coast to coast to coast, and in some cases beyond, lands that have been walked by Indigenous peoples since the beginning. I personally am joining from the area near where the Ottawa and the Rideau Rivers meet, which is traditional unceded Algonquin territory, an area that I'm so fortunate to be able to live and work on, and an area that I've been learning more about. And as I've been learning more, I've learned that this is an area that has long been a place of learning and exchange, where rivers have brought people together to be able to share stories, share knowledge, share learnings. And so I hope in today's virtual way, we can continue that tradition right across the country. And I invite you to pop into the chat, introduce yourself, and indicate where you're joining from. And if you're not sure about the area where you're joining from today, we've popped into the chat a link to the Native Land website where you can learn more about the territory that you're joining from. Friendly reminder that if you have any technical difficulties today, tech support is available. Feel free to reach out to our producers via the chat. And as we begin today's conversation, we want to recognize that talking about harm isn't always easy or comfortable. So we encourage you to take care of yourself today, and we'll be posting links to mental health resources in the chat if you need additional support during or after the webinar. Now, as we get started today, I'd just like to remind you that we've got wonderful luxury of having hundreds of people joining us from coast to coast to coast. So if you're not speaking, if you can keep your microphone muted, that would just be helpful to make sure that everyone can participate well in the webinar today. And so great to see folks from right across the country popping into the webinar and indicating where they're joining from. Glad that you can join us. So we're kicking off Canadian Patient Safety Week together today. And Canadian Patient Safety Week is an opportunity once a year to touch down, to hopefully get inspiration in terms of the amazing work that's going on to improve safer care, to reflect on where we've come since the last year, and also to be able to look ahead and think about what commitments we can make to improve safer care over the year to come. Encourage you to join us in CPSW activities right across the country, whether that's highlighting what you're doing and the inspiration that you're finding through social media or through other means, to visit our website, to access patient safety swag that you can use year-round, not just this week, to think about what patient safety activity might be helpful in your context, to join with us on a series of upcoming webinars, to use our activity card, to talk with other folks within your community about what harm looks like, what opportunities there are for safer care, and to access lots of additional resources. So there's on-demand learning and patient safety essentials, for instance, the Rethinking Patient Safety discussion guide, and lots of other free resources to hopefully motivate and inspire patient safety work all the way around the year. So with that, let's dive in to our conversation for today. So for those of you who like formal objectives, you'll see them on the screen. Hopefully today's webinar is really about opening a conversation amongst our panel, amongst all of us on the webinar, and hopefully scaling and spreading beyond that as well, so that the ripples can continue long after this webinar. We're focusing in on the focus area of CPSW's theme this year around healthcare harm. So to really reflect on the scope of harm, what that looks like, and the different types of harm that can be experienced. To understand and consider the impact that those different types of harm have on individuals, on families, on communities. And to think more broadly about our perspectives on safety, recognizing that what got us here may not get us there. And so healthcare harm rates have been stubbornly high since the pandemic began. The latest data from CIHI shows that they have stayed at the level that they've been at in recent years. So if we want to turn that around, we need to think differently about patient safety. And that'll be a jumping off point, hopefully, for inspiring action and learning as well. So with those slightly lofty goals for an hour, we'd better get started and get going in terms of what we're talking about. And this year, CPSW 2024, Canadian Patient Safety Week 2024, is really about broadening our understanding of healthcare harm, thinking about what makes us feel safe and what are the ways that we can understand and reflect on that and the opportunities for improvement. In fact, the artwork that you see on the screen, I think beautifully captures this year's theme. It represents to me the essence of the campaign this year, about all of us coming together, regardless of our roles in the health system, but coming together, asking meaningful questions like what matters to you, and then truly listening to understand safety and healthcare harm from different perspectives. That's at the heart of what we're hoping to bring forward with Canadian Patient Safety Week this year. And as part of this year's campaign, we've pulled together a set of resources to make those insights from what people have studied around the world, what we've heard from those with lived experience, as well as opportunities for broader connection. And so the infographic really reflects the fact that, and we've got a link coming up in the chat if you haven't seen it yet, the infographic that we've pulled together to summarize that information really reflects the fact that our healthcare system is incredibly complex. And most of the time, very fortunately, that system is safe. But that's not always the case. And if we want to be able to promise those who access care, those who provide care, patient safety, that means thinking about not just physical harm, important as that is, but also thinking about psychological harms, social harms, spiritual injuries that can occur as well. And recognizing that healthcare harm absolutely can be experienced by patients and also residents, clients, healthcare partners, clinical and non-clinical staff, and communities as a whole as well. And so if we want to tackle those challenges, the person or the people who've experienced harm are really those we need to listen to most. They're best positioned to define it and describe the impact on their lives, which is, at the end of the day, the overall theme of our webinar today, to broaden understanding of the perspectives on healthcare harm and to think about what are those reflections on harm, what's the impact, and what are our opportunities to improve in the future. And to do that, I want to invite our panel into this conversation today. So we are very fortunate to be joined by three wonderful panel members. And as we begin, I'm going to invite each of them to introduce themselves and the perspectives that they're coming to this conversation with. So Samaria, you're on the left-hand side of the screen. I see you up there and ready to go. Do you want to jump in?
Thank you. Oki, Tansi, Danatara, Avawastich. Welcome in the languages of Treaty 7. I am Samaria Nancy Cardinal. I am a Master of Social Work in Clinical Practice. I am an Indigenous Therapy Specialist and a registered social worker. I'm also a healthcare advocate and a member of Patients for Patient Safety Canada, and I will be speaking from the patient perspective. Thank you.
Thank you so much. Terry.
Morning, everyone. My name is Terry Wild. I live in the beautiful Eat Souk near Victoria, BC, on the lands of the Lekwungen and Wasanic and Souk people. I'm my trade is I build houses, specializing in healthy construction. I love walking on the beach with my dogs, and my new hobby is West Coast swing dancing. I come from the experience of a patient and a caregiver, experiencing harm and experiencing gaps in care in the system, and that's a perspective that I'm bringing today to the work. Thank you.
Thank you so much, Terry. And Ben, I'm going to turn it over to you, both to introduce yourself and I think a creative approach to describing the perspective that you bring.
Thank you very much, Jennifer, for your land acknowledgement and for inviting me today. I'm on Treaty 6 territory. I'm a general cardiologist and I do internal medicine as well in Saskatoon. And I'm an associate professor at the University of Saskatchewan with a master's in health sciences. I engage in research that main focus is to improve the safety of care for vulnerable populations, especially as they enter the system through the hospital. One of the ways over the years that I've learned to cope with adverse events that I've been involved in is to engage in poetry. And one thing I want to do today is to share a poem that I wrote several years ago when I was feeling particularly sad about a case, and the story of a patient who actually inspired me through that situation. Dear patient, I'm a compassionate and competent physician. This is my job. I will help you pick the right medication, or I can hold your hand when you sob. My ultimate purpose is to make you feel better. I spent years studying the subject matter. Sometimes I stay up late studying you, trying to come up with the right thing to do. Even with all this effort, despite my best intentions, I fall short and cannot help with your tribulations. Sometimes I falter and make mistakes. Hard to believe with such high stakes. I wish I could be perfect and not feel this way. Your life was in my hands today. I wish I could go back and do things differently because you could look at me instead happily. So sorry for what happened. This was not what I intended. It happened so fast, and I cannot change the past. It's not fair that this happened to you. I should have been looking out for you. How can we move on from this tragedy? Should this be the end for me? You say that is nonsense. You tell me to focus. You urge me to practice. You are so courageous. I should find the problem. I should analyze the steps. There's hope to next time prevent this mess. Your endorsement means all, catches me when I fall. Nourishes my broken spirit and keeps me standing tall. Instead of wallowing in self-pity, I will talk to the quality committee. I need to know I have done everything to keep this from recurring. We can all help prevent errors, and when they still happen, we have to discuss them and make a plan to address them. I'm writing to thank you for helping me see that my mistakes should not define me. Your courage will be my inspiration. Be a compassionate and competent physician.
Thank you so much, Ben. And on behalf of everyone who's writing into the chat and who's commenting, appreciate the poetry that you shared, your sentiments, and your big heart as well. And we are hoping to have a conversation today, a conversation, yes, amongst the panel, but also amongst everybody who is joining us for today's conversation as well. So we're going to start off with some questions for the panel, but as you have questions or reflections, anyone, please feel to pop them into the chat. I will try and weave them into our conversation with the panel as well to keep things going. So we're going to start today's conversation with the panel and invite each of you to reflect on what healthcare harm means to you. And Samaria, maybe we'll start in the same order as we went before, and then I'll mix it up after this. So you're not always going first, don't worry. But can I start with you? What does healthcare harm mean to you? Oh, and you'll have to unmute. There we go.
Now, healthcare harm, that is a huge issue. I am Indigenous, and more harm comes to people who are Indigenous in Canada. And for me, healthcare harm took away 15 years of my life. And it took everything from me. And I had to fight to come back to who I was as a person again. And thank God I had the strength to do that. But it also, a big thing, it did change my life going through that, because what happened to me inspired me to go back to school and to become an Indigenous therapy specialist. And I'm now a mental health professional, so that I can provide culturally appropriate therapy to Indigenous individuals so that they are not harmed. So it created a spark in me to do something, and I became a healthcare advocate, and I fight for change. So I know what can be done, and we have a lot of beautiful people in our healthcare system. We all want to create a wonderful experience for people that are seeking care. And so I think, as long as we stay together and we stay motivated, we're going to be able to do it.
Thank you so much for those reflections and that focus on together, that it's going to take all of us to do this work. Absolutely. Terry, can I invite you to weigh in? What does healthcare harm mean to you?
I just want to remind people that I know that there's many people on this call that have experienced harm, and while we move on to safety, but we are talking about harm. I just want to remind people to take care of themselves, and I know that it can sometimes be triggering. So when I think of healthcare harm, I can't not think about the experience of my late wife. My late wife, Lily, was an artist, painting award-winning paintings and writing poetry. A mother. You'll have to excuse me, I have a bit of a sore throat right now. Active and giving in her community, full of life and wonder, and inspiration to many. And when she was able, she was an advocate for others with rare diseases. Lily suffered a lifetime of poor medical care and many instances of healthcare harm leading up to her death. As a rare disease and chronically ill patient, Lily experienced many instances of delays in diagnosis, wrong diagnosis, and harm. And even when she had a diagnosis, I heard doctors say to her, "We don't believe in that diagnosis. We don't believe you." Meanwhile, she was living with recognized diagnosed conditions. The harms Lily experienced were not only physical harms, but psychological and spiritual. When she was suffering with life-threatening flare-ups of her conditions at home, she would weigh in whether she felt safer treating that life-threatening condition at home compared to getting in treatment in a hospital where she'd experienced unsafe care and harm. For Lily and many chronically ill patients that I know, getting care is a challenging process. They have many misdiagnoses along the way, or times when symptoms manifest, it gets ignored because it gets blamed on existing conditions. Lily and other patients like her are like the canaries in the coal mine. They pay the price for the failures in our medical system. Thank you.
Thanks for sharing those experiences, Terry, and thank you for the reminder as well, that sometimes conversations can be very difficult, that it's important that everybody today take care of themselves. And just a reminder that we have popped some resources to support that into the chat as well. Ben, you're coming from a slightly different perspective today, but a deep understanding of healthcare harm as well. What does it mean to you?
Thank you to my co-panelists for sharing. I would say that I come at it from the angle that I treat a lot of vulnerable populations, so patients who've not had access to the same things, growing up or even currently in their lives, including housing, social support, family, and recognizing patients' trauma and where they're coming from is absolutely essential when they come into hospital. Otherwise, the usual assumptions that we make as physicians, like, oh, patients feel safe in the hospital or patients expect good care in the hospital, we can't make those assumptions. We need to start from a different level. And so the main part of our research group's goal is to figure out where people are at, understand how to build trust so that we can make the hospital a positive experience and avoid things like stigma, discrimination, and patient-directed discharges. And so as a cardiologist, I'm particularly interested in heart infections called infective endocarditis, which disproportionately impacts people who are homeless and who inject drugs. And without approaches like that that are, more intuitive and that engage patients, they have very poor outcomes.
I really appreciate you sharing that, Ben, sharing both the fact that not everyone is has the same experience of risk, and also that deep listening and powerful presence can be so important in patient safety. And I wonder, Terry, in that context, if I might circle back to you, because you also talked about the importance of feeling seen, heard, and understood. And what does that look like from your perspective?
Yeah, well, I was going to talk about that more later on when you ask more questions. But for me, being listened to as a patient is really key. And actually, it's for everybody in healthcare, being listened to and being heard, whether it's staff, whether it's patient, whether it's caregivers. That's such a crucial piece of safety from my experience.
Sorry for jumping the gun a little on the questions that you wanted to bring forward. But I do just want to stick on this for a minute because Samaria, I saw you nodding as well as Ben was talking. Did you want to add in?
Yes, with my experience, I was not hurt. When everything happened to me, I was going to university and I had a child, and I had actually had postpartum syndrome. And what happened is they misdiagnosed me with bipolar disorder. And that came, with that came 15 different types of medications that I lost my ability to drive. I could not be a mother. I sat and drooled. I had to have access, it's called access in Alberta, to drive me anywhere. I lost all of my capacity, and none of those drugs were working. Yet they still continued to give me more. They would not listen. At one point, I even went to them and said, I can't even remember anything anymore. So they gave me an Alzheimer's test. And when it came back, they told me that I had lied on it. I was so bad. And I said, I never lied on that test. They did not believe me. They would not listen. I would ask for help. I would beg for help, and they never provided it for me. And I ended up homeless on the street because of it. So this is what happens when you don't listen to people and you tell them that they're lying. And you know what? Listen to the patient. It's really, really important. They need to be heard.
Thanks for sharing that, Samaria, and for just holding at the core the power, the importance of listening, and that centrally, you as a patient, each of us, when we're a patient, we're the experts in us, right? And in who we are and our experience that we're having at that point. Ben, I'm wondering if I can turn to you next, and switch the side of the gurney in a way, and bring in your perspective. You work with folks, as you mentioned, who have some challenges in their lives. You talked about the importance of listening. How do we do that well as a system?
So the short answer is that the system isn't very well equipped to, provide that service. And I think the reason that that's the case is multifactorial, but especially post-pandemic, patients are presenting with even more trauma. The healthcare system is even more stretched than it was. So some of the inefficiencies that used to exist are even worse. And so one thing that we've done, because we recognize that certain patients need more time and more support. It's like that, classic picture of the fence where everybody gets a step so that there's people at different heights all trying to look over the fence. And if you give everyone the same size of steps, some people will still not be able to look over the fence. And so we try to figure out, how to get people even higher. And so that takes time and more people ultimately. And so when we enroll a patient, we figure out, first of all, who they are, where they're coming from, what are all the issues that we need to surmount before we can even talk about their medical condition. Because a lot of people who present to hospital are in survival mode, like what Samaria was describing. And what Samaria actually needed at that time was a holistic, you know, picture and a holistic assessment of what was happening to her. Um, a pharmacist needed to review her medications in detail and connect the dots about how that was impacting her. And, we need a social worker to help patients access housing or access more supports in the community so that they don't have to, come back to hospital. And so there is this trend, unfortunately, that more medications will cure disease, and modern medicine, unfortunately, is a bit biased to that perspective. But the more I practice, the more I've actually realized that I just need to get better at figuring out what's impacting patients' lives and engaging, an allied healthcare team to support them. So long story short, I do think that we need more of a focus on social determinants if we want to rescue our system from harm.
Thanks, Ben. And as Karen said, equity versus equality, how do we think about equity in what that we do? Terry, your hand's up. Coming to
Yeah,
you, and then I'm going to bring in some of the comments in the chat as well. So over to you next.
I just wanted to expand on what Ben was saying about equity versus equality. Now, in that example of the fence, everybody can't see, so then you give the tallest person can see over the fence. That's great. So we think of it as an equality improvement cycle process. Or the medium person, we give them one stool. The shorter person, we give them two stool, and that's we're doing quality improvement. Well, let's think of whole system quality, and let's remove the fence. Just as we think about that.
I love that analogy, Terry, in terms of, we got to think outside the box, right? We've got to think differently than the ways that we maybe already have. And Samaria, I see you nodding your head on that point. I also wanted to bring in a couple comments in the chat that we're looking at. Also, how do we, as we're thinking differently, think about community, not just individuals? What's that combination of things we need to think about?
Well, I think it's very, very important. One individual has one idea, but when we are with a community and everybody can put input in and have this discussion about what's best for the community, then more ideas are generated, and it creates a better pot of information for everyone to access. So I think it's really important that, and this is something I really have an issue with Western society, is the individualism that takes place. And when we work together as a community and get out of that I type of situation, then we can all work together and we can have interdisciplinary experiences between the professionals. We can all get along and we can all talk, and then we can create a better system instead of this I thing.
So as we're thinking about that, as we're thinking bigger, Ben, I'm going to turn it back to you. To use Terry's analogy, what does it look like to take down the fence? Where have you seen that starting to happen? What are some of the things that you've seen to help focus on equity?
First of all, that's a difficult question because
No easy ones here today.
we'd of course love to take the fence down. But I mean, again, if I'm trying to avoid self-promotion here, but it's, my everyday life is to work with these patients and try to break down barriers. But one of the things that we identified when patients who are vulnerable come into hospital is the history. So it's so basic, but the history gets perpetuated, assumptions get made about certain patients, like, oh, you injected drugs in the past? Your heart infection's for sure from drug use. There's no question. We're just going to put that in the chart. Even though patients, for example, had been sober for years and it was completely irrelevant, and actually their infection came from their teeth. So one of the things we've done to really remove the fence is we don't trust the history until our dedicated social worker goes over there and takes it properly. And then it's inked in the chart what actually happened so that we can avoid misinformation getting perpetuated in the chart. And so that way that person, we've removed those barriers of, assumptions that were made. And so then, a person who is perhaps more privileged where assumptions weren't made, who had a good history taken, well, we've brought them up to that level playing field, right from the get-go. So hopefully that was a good example, but that's one thing that we're doing.
Thanks, Ben. And I think you've just passed the baton to Samaria as a social worker. Although, Samaria, you may want to comment from multiple perspectives.
With that, it's really, really important that we see the person as an individual walking in to seek help. I know for myself, they had given me the diagnosis as bipolar. And I remember years after I walked into a hospital emergency room and I was having issues with my chest and my heart and stuff like that. And the first thing the doctor did is he goes, "Oh," and he looks at my chart. "Have you taken your medication today?" And I know what he was referring to. And I hadn't taken those medication in years. And that diagnosis should have been off the chart. And I just looked at him and I said, "This has nothing to do with those medications." And so he was labeling me right from the beginning without he didn't even look at my chest. And so, and also when Indigenous people go into emergency rooms and say they're in a lot of pain, a lot of doctors will look at them and think they're drug seeking. And they will not get the pain relief they need. Yet beside them will be a non-Indigenous patient. And that person, they'll give them every drug that they could ever want. So really check your biases at the door and see that person as a human being. That's really, really important.
Thanks for emphasizing that and just bringing that focus back to that person at that time and their circumstances and where they're at as well. There's been a question that's come up in the chat in terms of what's the role of technology in improving safety? Where are there opportunities? And this wasn't a question that we discussed in advance, so I'm going to see who wants to jump in. Ben, I see you nodding, so maybe I'll start with you, and then if anyone else wants to start, wants to add on, we can do that. But Ben, over to you.
Sure. Thank you for that opportunity. I think like on the same vein of information sharing, like some centers do this a lot better than Saskatchewan, I'll admit. But for example, if my patient that I've been following, even if it's for years, who comes to emerge, that emergency physician does not have a reliable way to access my clinic notes, which would be infinitely helpful. And so if we had a more centralized information system or something built into our system to say, oh, this is Ben's patient. Okay, let's get the last clinic note because like the guy's gotten to know this patient for 10 years. Like that would really, really help for sure. So that's like low-hanging fruit, but it's very challenging. All outpatient clinics are very disjointed. Some of them are not even affiliated with universities or hospitals. And so it can be very challenging. And maybe we should even go a step further. We should have physio reports available, dietitian reports available, social work, et cetera. Pick your allied health. It would be a wealth of information that'd be really helpful.
Not seeing either Terry or Samaria, just checking if either of you want in. Terry.
Yeah, I'll weigh in on that. Are we talking about like information technology? Data is really a challenge right now. A lot of the harm I've witnessed has been that the patient records aren't available, or I go from a primary care provider in the same health system to a specialist and they don't have my records, and they spend half the time writing down notes on my chart that they already in my records, but they don't have them. And I've seen referrals get lost, causing harm. I actually just had a friend of mine recently that he had a delay in diagnosis, and part of it was the information not getting to the specialist. And now his cancer diagnosis is stage 3 or 4 instead of stage 1, and we're just hopeful that it will turn out okay for him. But meanwhile, harm is done, and that's for lack of technology. And then when we talking about technology with the AI, I think it's coming whether we like it or not, and we need to figure out how we embrace that in healthcare, because there can be a lot of challenges and errors with it. That it could be really helpful in sharing information, breaking down silos, and for patients to get diagnosis for their conditions, even that they can then check with their provider on. But it comes with a big caution. So it's something we really do need to focus on, whether we want to or not, because it's coming.
I really appreciate that reflection, Terry, that, as changes are happening, we need to be thoughtful about how they're being introduced, because new technology can be a real driver of safer care, and it can carry risks. And so how do we make sure that we're thinking about safer care by design? Ben, you had your hand up.
Only if Samaria has nothing to say, because no, I just wanted to build one further point on the technology piece. So as patients move through the system, information obviously needs to be shared. But outpatient follow-up, so rapid outpatient follow-up and feeding back to referring physicians about what's happening is also something that happens inconsistently. So again, building on that kind of information sharing piece.
Really appreciate that the absence of an action or the absence of information sharing itself creates risk as well. I wonder if we can change topics a little bit for what's in the chat. And Samaria, I will come to you on this one first to make sure you get a chance to dive back into the conversation. A number of folks have raised the fact that harm may happen at a given time, but then there's what happens afterwards. And how do we make sure that what happens afterwards is done in a good way?
Yes, I think that's really important, because when patient harm occurs, the person, like, I know how I felt. I was so angry and I didn't know who to go to. And at one point, I had the whole report all written up, and I was going to send it to the Medical Association. And back then, I really didn't understand the system. And I was told by multiple people that if I did that, I would never get proper care again from a doctor. And so I was terrified. I did not understand the system. And so I didn't do anything. But I did get the strength myself to start doing healthcare advocacy and start educating people on what can happen. So I needed somebody. I needed someone to help me, and I had no one. I was literally out there with my hands out going, please help me. Like, your drugs aren't working. Nothing's working. I am crying for help. But they didn't listen to me. They gave me shock treatment that I didn't ask for, which has created, I do have issues with memory now because of it, but I have workarounds for it. They've done a lot of things, but they never gave me what I deserved and what I needed. So I had to go out and seek all that myself, right? I went back into my culture. I found myself spiritually again. I went to my healers, and I went back to school. And I did it all on my own without professionals, because at that point, I no longer trusted them. So that's something to consider, what can happen when you do that to an individual. I walk into an office with a healthcare professional, it doesn't matter who they are, and I'm just looking at them sideways until they can prove to me that I can trust them. Because I'm no longer that trusting young individual that this happened to. But you know what? There's so many people out there that still trust everybody they come into contact with. When I was younger, I thought health professionals were gods. They did not make mistakes. And boy, did I learn wrong. You know, and nowadays, when you go in and you see a health professional, you have to advocate for yourself. You have to fight for the health you need. Because I had an issue with I had just had bowel surgery in May. I had diverticulitis. I was going to doctors. They're misdiagnosing me again, putting me on the same antibiotics. I became antibiotic resistant, ended up having to have a huge operation. Part of my bowel was taken out that was calcified, right? I fought for 3 years to get that looked at. All the while I was in school with a master's and trying to do that at the same time. But I did it because I was really strong. But I had to fight for everything I got. So yeah, it's very, very difficult what happens to a person when you go through that. And when you think of so many people are going through it, it just hurts my heart when I think of that. And some people aren't strong enough to fight. They don't. And they become the victims. And that's the saddest thing that I can think of.
It's a complicated path and not an easy one, for sure. Terry or Ben, do either of you want to weigh in on what happens next? And how is it possible, as someone said in the chat, for that mutual rebuilding of trust to happen? What does that look like? Oh,
I
Terry,
think
you're on
Terry
mute.
is speaking. He's just, unmute yourself, Terry. I want to hear you.
Sorry. Yeah, I just want to acknowledge, the harm that Samaria had suffered, and that, that trust is an important piece. If you don't have trust, you don't have safety. And so that's such an important piece. The patient needs to be able to trust the caregiver. The caregiver needs to have trust in the system they're working in. And I think we could do a lot for safety in the presence of safety if we work on that trust piece.
Thanks, Terry. Ben?
I'll just add that, first of all, it breaks my heart hearing your stories. I'm so sorry that happened to you, Samaria. I think a first step for physicians is acknowledging the harm. And I mean healthcare practitioners in general, and mustering an apology, even if problems and adverse events are multifactorial. That's always a good starting point, is admission that somehow, either willingly or unwillingly, you participated in this adverse event, and that you're apologizing in order to work on rebuilding that trust, acknowledging the harm that occurred, and then creating a safer place and learning from that experience. So that's that's certainly what I try to do in my practice. Is that easy to do? No. Is there like a clear path? No, it's sort of a case by case, but this is certainly something that we have to work on as a profession.
Thanks, Ben. I appreciate that comment, that both there's a starting point and then there's a working on. And it's not a one time, it's a process over time as well. I wonder if, Ben, this might actually come back to you. A question in the chat about language barriers and how that can affect patient safety. I don't know if that's been you've had that experience clinically
Yes, definitely. So I'm lucky enough to be bilingual, so I speak English and French. But I know a lot of my patients speak Cree or Dene, and so having family members there to help translate is super critical. And so one thing that's opened my eyes is since we've had a dedicated caseworker, she'll be like, "Hey, Ben, you know this person's first language isn't English, right?" Even though they speak English fairly well, like a lot of patients can fake it or they're too embarrassed to bring it up. And so that's huge. Communication is the basic basis for advancing care and understanding where patients are coming from. So being very conscientious of their first language, particularly as we know that when patients are sick, they tend to revert back to their first language of that, especially, even post-stroke or in when they're critically ill, that tends to be the best way to communicate with them. So wearing pins saying, "Hey, I speak this language," can be kind of a passive way to let people know that you understand their language, or just making that a part of your daily routine. Like, what would be your preferred language to proceed here today? And then going from there.
Thanks for sharing that. And, a good friend said to me many years ago, when I'm sick, I'm not bilingual. And so, even if in other circumstances you might be perfectly comfortable when, it's a high stress day, when things aren't going well, that just ups the ante. And for anyone who hasn't seen the latest data from the Canadian Institute for Health Information on hospital harm, they actually analyzed people who spoke English and French and those who didn't. And the risk of harm was 30% higher for those who didn't speak English or French as well. Samaria, I saw you nodding, so I don't want to put you on the spot, but if you wanted to jump into the conversation, wanted to hold space for that too.
No, I'm okay right now. Thank you.
Okay. It's always the challenge in a Zoom webinar to figure out when are you just sort of agreeing with the sentiments and when do you have something to add along the way. There was a different set of conversations coming up in the chat, and I'm trying to keep up with the chat for those of you who are writing, so hopefully I'm not missing too many things along the way. But a reflection on the things that cause harm are not necessarily the things that make you feel safe. It's not just one's a flip side of the other. And Terry, I wondered if you wanted to jump back into the conversation you said you were going to come back to later with that as a jumping off point to say, what makes you feel safe? How does that play out?
Well, I'll just start. I'll get to that in 1 second, but I just wanted to say, patient safety for me is not just the absence of harm, but the presence of safety. So the presence of safety is focusing on moving forward with safety embedded in everything we do, not just an add-on. Where we spend a lot of work looking back over mistakes and fixing things, and that's important. As somebody that has lost someone to healthcare harm, I know the importance of that. But we need to look more of a culture of safety embedded in a whole system quality. And, patient safety means care for patients, safe work environment for providers. It's not only physically and emotionally and spiritually safe. So if we don't have a safe environment for our providers, we don't have safety for patients, and that's really important. And for me, feeling safe with care, like as a patient and caregiver, I could usually tell how safe the care would be by a few minutes or a few seconds actually into a conversation, whether I was interrupted or the patient I was caring for was interrupted by the provider before they could finish their opening statement. And, I recently had a misdiagnosis because I needed 20 to 30 seconds to say my condition. Provider interrupted me 5 or 10 seconds in and had made up his mind already, like, oh, but this is what it is. Gave me a prescription and sent me on my way, even though I asked about the differential diagnosis. I went to my pharmacist and described my condition and said, here's what I've been prescribed. I didn't say that I had any concerns about it. I just laid some facts out. And he says, that would probably cause harm and not cure your condition. Here's what it is. It cleared up right away. So that was just going back to the importance of listening. So when I've been listened to, when the patient I've been supporting has been listened to, automatically there was a presence of safety. There was more safe care, even if they didn't know the diagnosis, even if they couldn't help at that time. it was important that they didn't cause harm, that they didn't cause emotional harm of I'm not being listened to, I'm not being heard. And then it's a matter of, well, what can we do to help you? Can we refer you on or not? But having that, really being listened to. And I know in healthcare settings, the staff, the providers, everybody needs to be listened to and be able to speak up for safety in a safe culture. Thanks.
Really appreciate those reflections, Terry. And Samaria, maybe I can offer you this space as well. What does the presence of safety look like to you? To Terry's point, not merely the absence of harm.
Presence of safety means that I'm not afraid to go seek help when I have a medical issue. I am not afraid to go to that emergency room, and even though I have to sit 16 hours in there, I'm not afraid, right? I'm not afraid I'm going to die sitting there. And I'm not afraid that, and so that I'm not afraid that when I go in a room and the person knows I'm Indigenous, they're going to be racist or have a bias towards me. Safety is when I go in a room and I explain to the doctor or whatever healthcare professional, whatever is happening to me, and that they listen. And they listen with intent. And they really listen. And they don't make assumptions as I'm talking. And they try their best to help me. And that may not be giving me medications. That may be giving me a referral somewhere. And if they are referring me to someone, don't just refer me to anyone. Because I've been referred to specialists that I walk in the room and the whole appointment is I'm being gaslit. And I'm being told that my symptoms are, they can't be that bad. And I'm not listened to. Yet, there are some times that I've had to stay with those specialists because I've tried to get referrals to other specialists and I can't get them because they're being blocked. So being safe is knowing that when you have an issue, you can get the help you need. You don't have to fight for it, that you're going to be treated with respect as a human being. And that person with all their training is going to be able to assist you the best they can with a kind heart. That's what safety is to me.
Thanks for sharing that, Samira. And isn't that the promise that we want for each and every person? No matter where they walk into, no matter what they look like, no matter what they had for breakfast or what language they speak or anything else, that promise of being seen, being listened to, being respected as well. I can't believe how time has flown by, but I did promise our panelists that I would give them a speed round at the end for a key takeaway that they want to leave folks with. As we come towards the close of our webinar for today. So I think we might go backwards, Ben, if that's okay, and start with you. What's your key takeaway?
I think as a healthcare provider, hearing Samaria and Terry tell their stories and their priorities, I want to send out a call to action to all healthcare providers to really acknowledge your biases before you go into the room. Try to understand, have you jumped to any conclusions before you've actually listened to what's happened? And so figure out a way to build that into your practice. Go to seminars about bias, learn about your bias, because in my experience, a lot of them are unconscious. And so you're not aware of them until you reflect on them.
Thanks, Ben. Terry, key takeaway.
Yeah, much of the harm I witnessed could have been avoided if workers had felt safe to step up and speak up, if caregivers and family had felt safe to step up and speak up, if patients felt safe, without the fear of being labeled a difficult patient and it affecting their care, as we've talked about earlier today. As a patient safety advocate, it is important to work together to improve safety. Patient voices need to be heard, But to have the patient safety, we need to have health worker safety. You cannot have one without the other. In my work, when I speak up to ask for patient voice to be heard, I also speak up and ask for health workers' voices to be heard. Healthcare provider safety and well-being is vital to patient safety. Nurses and doctors are overburdened, understaffed, and burning out. I feel the burden of harm they face. This contributes to an unsafe environment. We need more supports for working together to improve care, create a culture of safety in all areas of healthcare. I've recently done work with healthcare organizations in BC in creating policy by having all stakeholders at the table: patient, community members, Indigenous partners, healthcare providers, administrators, and industry, patient safety professionals. We had all these perspectives together to create a better healthcare system. We are in this together, we're stronger together, and together we will build a strong, safe, and inclusive healthcare system. Thank you.
Thanks so much, Terry. Love that, both and, not either or. Samaria, key takeaway.
I think the most important key takeaway from me is that I am not an expert on anybody and on anybody's life. So I take that into my practice as a mental health therapist. I tell my clients, I am not an expert. You are the expert in your life. I am somebody that is walking side by side with you on your healing journey. I have a toolbox that maybe you don't have, and that's why I'm standing beside you. But you're the driver. I'm just a passenger on this, and I'll help you any way I can. And I think if more health professionals take that attitude, things will change.
Thank you so much, Samaria. I love that image. I have that image now in my head of walking side by side. I really appreciate that. And hopefully lots of side by sides, because as we've talked about in this webinar, there's a whole bunch of people, all of us have a role in patient safety. So this is the point where if we were in a room, there would be thunderous applause when I invite everyone to join me in thanking our panelists. Looks a little bit different on a webinar, but I see some clapping hands on Zoom, and I know everyone would join me because there's been so many lovely messages in the chat in appreciation for all of you sharing your own experiences, the experiences in which, to Samaria, your point, you're an expert in your own life and that own experience, and then also sharing how that may be relevant in terms of informing the approaches we take to continue to push like that, set of waves that come up and gradually improve safety with and for everyone across the country. So huge thank you to each of you. Thank you to everyone who's joined us here today. I hope you found this session helpful to start off Canadian Patient Safety Week and our conversation around healthcare harm. I invite you to join us to dive deeper into some upcoming webinars, both this week, and because Canadian Patient Safety Week shouldn't just be a week, even though week is in the label, also to join us a little bit later on for a discussion around courageous leadership as well. You can follow the QR code there, or we're posting links in the chat. And then if you're interested in either yourself or with others who you work with, getting more knowledge on the fundamentals of patient safety, we have recently updated Patient Safety Essentials. So this program used to only be offered in person, which meant that we could only offer it to so many people. Now there's a whole self-directed free online learning approach. And we invite you to participate in that program as well. You can just get started at any point, either in English or in French. And then finally, as an improvement organization, we believe that we need advice and feedback as well. So I would ask for your indulgence in giving us a bit of feedback on this session. You will see there's a couple questions there. So hope that you'll be able to help us by answering those questions in the poll. And notice that you may need to scroll through and click before clicking submit. Otherwise, it may be cranky and Zoom may not let you actually submit your response. So once again, as folks are completing those surveys, Ben, Samaria, Terry, thank you. Thank you so much for being willing to share your stories, the hard-won lessons learned, and joining us for today's conversation about healthcare harm and all the work that you do each and every day to improve safety as well. Thank you.
Thank you. It was an honor to be here today.
Thank you
Agreed.
so much.
Thank you.
Nanasko Mitin.
Thank you. So as we're hitting the top of the hour, this officially concludes our webinar for today. I hope that you'll join us for other events taking part during Canadian Patient Safety Week, that you'll do your own too, so that there's a whole series of events happening across the country. And thank you to everybody who's online for caring about safety and for acting towards safer care as well. Have a good day, everyone. Thanks so much.